Dear Carol, ladies and gentlemen, so I will start with something that has revolutionized our work in ultrasound, that is contrast media. So I will talk about SEERS of the liver and the gallbladder. So you know that in Europe and in most Asian countries there are at least one contrast agent being approved, and we now have Lumason, that is Sonoview, name here in the US, but it's only for left heart approved here in the US, so not for abdominal studies. So what are the strengths of SEERS and why do we love that? Number one, it has a high temporal and spatial resolution in real time during all phases, advantages especially during the arterial phase. It is a multiplanar imaging technique. It has no exposure to radiation. We have, of course, as you all know, no iodine. We have no real elimination, but it will be eliminated by the lungs. No interference with drugs like metformin. We have bedside examinations, important, especially on ICU patients or emergency units, and it is repeatable as often as clinically indicated. From the EFSUM guidelines, we defined the three phases as the arterial phase starting roundabout, as we think, between 8 and 12 seconds, and the portal venous phase starts at 30 seconds after IV bolus injection, and the late phase starts after 2 minutes. And when we look at the arrival times of the contrast agent, and we looked at that visually, so this is a visual estimation of the arrival time in the hepatic artery. So the hepatic artery, it comes around about 9 seconds after IV injection. So this is a study that we did on 32 normal patients, and then we looked at it, or we checked when the first bubble appear in the portal venous system. That's round about 3 seconds later, and after 21 seconds, the contrast agent appears in the hepatic veins. So this is important because we can use these time differences to just only image the arterial system of the liver. So this is an angiography, hepatic angiography of the liver, as you can see here, of the right liver lobe. And when we come 3 seconds later, 2 to 3 seconds later, we will not only catch the arteries, but also the portal venous system. But of course, the arteries have a higher concentration of bubbles, so they stand out much more clearly and much more enhanced compared to the adjacent portal veins. And of course, we can look at the cirrhosis. So there are big changes, of course, in cirrhosis. So this is biliary cirrhosis, and you can see a tortuous course of the arteries. And what you can also see is that during the arterial phase, the liver tissue is already enhanced, unlikely in, or not the same as happening in normal livers. And of course, we can also use that in order to detect the tumors that are enhanced during the early arterial phase, as you can see it here. This is a patient who had a hepatitis and developed cirrhosis, and this is an HCC not being seen on CT. Okay, so this is a patient who was referred to my lab because of elevated liver tests, but on CT there was a cirrhosis being diagnosed. But what you can see on this grayscale image is already that you have dilated and tortuous arteries in the liver. And when we look now at the arterial phase, then you can see from this subcostal approach that we not only see the arteries at the very early time, but we also see portal veins being filled already, number one. And number two, if we stop this loop and we go back, or forth, then you can see here we have already contrast agent in the portal venous system, not in all, but in this one. And when we go further, then we see here the hepatic veins are filled. So we have, number one, arterial portal shunting, and we have arterial venous shunting. So that is important. And if we look now, why does CT say there is a liver cirrhosis? Probably because of these tiny nodules. And these tiny nodules are the shunts, hepatic shunts. So this is a patient with Osler disease. So typical finding. And of course, we did not biopsy this patient. Okay. So what is the indication for contrast agent in the liver? And later I will talk about the gallbladder disease indications. It's number one, detection and characterization of focal liver lesions, including trauma. Follow-up under chemotherapy, ablation therapy, surgery, or spontaneous cause of disease. So when we look at the benign and malignant liver lesions, then we can discriminate both with the benign solid lesions as being hyper or iso-enhanced beyond the portal venous face. And that is true for FNHs and hemangiomas that are the most frequent benign lesions. And the malignant lesions, they wash out during the late arterial phase or early portal venous phase. So the malignant lesions are best detected during the portal venous and the late phase. So, and we have, and maybe we should also talk about that, it is a very reliable sign. So we have an accuracy of 85 to 88% and a diagnostic confidence of 0.988. So this is from a study by Quaia, an Italian radiologist who did this work in 2004. So, and of course there are very typical findings, as you know it also from other imaging modalities. Like here you can see two neighboring hemangiomas, and you see what is typical on grayscale. We have this echogenic rim around this lesion. And when we look at it with contrast, then you can see that hemangiomas are supplied by arteries, of course. So we have the first bubbles coming up during the arterial phase when the portal veins are not filled. So this shunting is also these arterial filling, these cotton wool signs, as it was named in former days. This is causing these hyperechoic rim around these hemangiomas. And when we look a little bit later, of course, then with this is after 1 minute, then we can see that the hemangiomas are nearly completely filled. So this is a criterion that we know from all other imaging modalities as well. So, and this is a patient, not easy to detect that there is a lesion here in segment 7. So if the loop is running again, then you can see here is a lesion. This is a young lady, 28 years old, no complaints, but that was detected by ultrasound. And so what we did is we looked with contrast with these angiography type of imaging, and then you can see how an FNH may look like. It looks like this here. You see a tortuous artery supplying the FNH. You can see the intratumoral vessels. And then, of course, you can play a little bit with this technique, and you can see now the contrast coming into these lesions. Okay, so when we look at malignant lesions, then we have the kinetics that you already know, of course. So we see some lesions pick up contrast very early, and hyper-enhanced lesion, even more enhancing than the liver parenchyma, but there are also malignant lesions that take up contrast earlier than the liver parenchyma, but not as strongly enhanced compared to the liver. And then we have those who wash out very early and who have less contrast enhancement over all phases. So due to our high temporal resolution, we can see that for a couple of seconds only. So in CUS, we see most metastases being hypervascularized. Okay, so we also look, of course, at lesions that are clearly malignant. As in this case, this is a female patient, 45 years old, with malignant melanoma, and you see multiple tiny lesions all round about 1 centimeter in size. Of course, we also do contrast in this case because this patient will receive chemotherapy, and in order to have a follow-up, then we would like to know about the vasculature of these tumors. So when we give now contrast, then you can see that the metastases are highly vascularized. As you can see it here, they hang up like fruits from a tree. So, and it disappears after a couple of seconds, so it's gone then. So it's iso-enhancing, and if you wait a little bit longer, then you can see they are all washed out. So this is and CT recognized also these, of course, these lesions, but they were characterized as hypovascular metastases, and they are hypervascularized. Okay, so this looks like a hemangioma, but you need contrast to figure out it's not a hemangioma, it is a metastasis of a carcinoid. It washes out during the late arterial phase. When you now look the lesion here. It's now washing out. The washout comes up after 10 seconds. So you have to have your images within these 10 seconds, otherwise you would not see this hypervascularized tumor. This is, of course, an easy job. This is an HCC and a liver cirrhosis. And, of course, we're looking for the supplying artery. How many supplying arteries are there? Here we recognize just one. And you can see just like a ball taking up the contrast. And, again, after a couple of seconds, it's becoming isoechoic with the parenchyma. Okay, this is colon cancer metastasis. It's hypervascular. It is hyperechoic. And when we give contrast, we see something that's also interesting, because when the contrast is coming, you can see this area here is hyper-enhancing, but there is no tumor. There's no tumor because we see, when we look very carefully, we see some metastasis. Here's a metastasis, here's one. And these metastases led to a thrombosis of the portal vein. Okay, now this is the portal venous branch, and you can see two strongly enhanced arteries, and you can see exactly where the contrast is stopping. So here's the thrombosis. And that is something that you can see only for a couple of seconds, of course. These are the still frames taken from exactly this loop, and you can see over time, here's the thrombosis. Of course, caused by these metastases. And there are other things that you can see quite nicely. So this is a metastasis also of a colon cancer, and you can see here arterial portal shunts. Why? Because this tumor now appears to be rather big, but if you wait a couple of seconds, then you can see the washout phenomenon. And then you can see that around this lesion, you see this shunting effect. So this rim around this tumor is due to shunting. So we have a big advantage in characterizing tumors also by looking at the shunt phenomena. And shunts happen very often. So this is one of the characteristics of tumor vessels, that they're shunting. And of course, we may also have misleading grayscale images like this here. This is a patient with a melanoma, and this looks like, with a curved array probe and also with a linear probe, just like a cyst. Okay, so then let's give contrast, and then we can see it's not a cyst. We have to be very carefully, especially in patients with malignant melanoma, in making the diagnosis of a cyst. So this is definitely a hypervascularized tumor. And we see another one that we didn't see on grayscale, and we didn't see the one that is here in the subcapsular area, and this measures 2 × 4 millimeters in size. And you can see, when the loop is running again, the supplying arteries of these tumors. Okay, now again, here you can see the supplying artery of this tumor here, and here's also an artery supplying this tiny one, subcapsular. Okay, this is also an interesting finding. So this is a patient that has been referred to our lab because of an inconclusive CT study. The CT study says we do not really know what that is. Is that maybe a cyst? Is that a tumor? So this is what we saw here. And I thought, looking first at the image, this is maybe a tumor in the biliary system, because it looks like a papillary tumor here. And then we gave no, we didn't give contrast. I show you first the MRI study. So this is the MRI study. And the MRI study says, oh, it's a benign tumor, and it's a cystic tumor. Okay. We don't think so. So now it is a biliary mucinous cyst adenoma. And what is characterized? We see all septa here are hypervascularized. And that is something that MRI did not detect. So, and that was a 3 Tesla machine. And so we have CT, we have MRI, both inconclusive of this lesion, but it was a cyst adenoma, and they have a likelihood of malignant transformation in 10%. So it has to be taken out. So this is a second shot. Here you can see this papillary part of the tumor, but it's mucinous stuff that is within this dilated biliary system. So, and again, this is the late phase, I guess. Yeah, it's after 2 minutes, and you can still see bubbles running through the septa. Okay, so what about the characterization? We have a German multi-center study performed in 24 hospitals, and more than 1,300 patients have been included. So the sensitivity was 95%, specificity was 83%, and the positive predictive value for malignant lesions was over 90%, and the negative also. So when we look at lesions, then we always compare ultrasound or contrast-enhanced ultrasound with other imaging modalities. But we have to be aware that this is not the best way to do it, because the gold standard is, in our eyes, not CT, not MRI, not SEOS. So this is a study from the French group, from Charmy and Lasso, published in 2008, and they were all these patients were all resected, segmental or liver lobe resection. So this is the gold standard. And what they did is they did not do 1 centimeter slices of the liver, they did 3 millimeter slices in order to really detect the tiny lesions. So this is why SEOS didn't perform that well. It's the same with the CT, MRI. Only intraoperative ultrasound did a little bit better with 90%. So looking at why did all these imaging modalities could not detect these tiny lesions, it is because 34% of the detected metastases were below 1 centimeter, and 2/3 of the lesions that are missed were below 1 centimeter. So this is the challenge, to detect the tiny ones. Okay, let me show you. This is a patient with liver metastasis. It's a breast cancer patient. And let's see if we really see the lesions. And we see the lesions, yes, we do see the lesions. If you look very carefully, you see tiny lesions, all lesions below 1 centimeter in size. And this is the left liver lobe. You see the tiny lesions here. And we measured, we counted more than 15 lesions. And CT didn't detect one of them. Okay, so this is another patient, suspicious liver lesion on B mode. And when you look very carefully, you see here in segment 6 a lesion. But we were not that convinced that it was really a metastasis, but when you give contrast, it is really a clear case. So you see several lesions, and all are clearly not enhancing in the late phase. Okay, detection of liver metastasis, SEOS versus CT. These are all older studies, so they all come from 2006 to 2007, and you see that SEOS and CT, the difference, or there's no statistical difference between or regarding the sensitivity of both techniques. Nowadays, I would say with the new contrast settings that we have, I think we perform better than the studies before. Gallbladder and SEOS. So what is the challenge? Cholecystitis, an uncomplicated cholecystitis does not require SEOS, because we can make the diagnosis by clinical symptoms plus grayscale ultrasound. Thickened gallbladder wall, edema, stones, positive Murphy signs, you all know that. SEOS helps to better understand the inflammatory process of the gallbladder wall and the adjacent tissue, and it is helpful in diagnosing ulcerative cholecystitis and to prove perforation, and thus helping to define when to operate a patient. So this is the big advantage, because many of these patients, when they come to the hospitals, already received antibiotics. And that will diminish the pain of the patient and the symptoms of the patient. Even laboratory findings are not that reliable. So complicated cholecystitis may clinically remain undetected anti-antibiotic therapy. That is very important. And the negative Murphy sign, it can be seen in up to 2/3 of the patients with gangrenous cholecystitis, as published in '89 in AGR. Okay, and yeah. And of course, it also helps to characterize tumors. I will show you later. So this is a patient with an acute cholecystitis. So this was also, from a clinical point of view, a clear diagnosis. But what you can see here is an ulcerative cholecystitis. You can see here that the wall of the gallbladder shows these ulcerations here very nicely. So then we say, well, when we talk to our surgeons, they are convinced when they see these images and they get operated on the same day in order to prevent perforation. Okay, so this was the same patient. This is the gross specimen. So this is very impressive, and we do see that. Okay, let's look at another patient. So this patient had typical right quadrant pain 4 days ago. Shoulder cystitis was diagnosed by the family doctor, and as the patient refused to go into hospital, he said, "Can you not try something else?" "Yes, I give you antibiotics." Okay, and then the patient went better, and then the patient was scanned from his family doctor, and he said, I don't like these images. Please go to the hospital." "Yeah, but I do not want to go there because I have no pain anymore. So why should I go there?" And the patient came in walking. Okay, just this is the background. Okay, and now you see this image of the gallbladder. You can see the stones, and of course, when you give contrast, you have the idea where the perforation is. Here's the perforation. That's no question. And when you show that to this patient, he says, "Oh yes, I believe you. I think I stay here." Okay, so this is a still image from that. Okay, so this is, of course, the other indication is, what do you do with a patient after shoulder cystectomy? So this was a patient who had a ulcerative shoulder cystitis and was operated, and then 4 days after surgery, he had no fever, he had no pain, but he has rising CRP levels and white blood cell counts. So this is why he was introduced to us. And what you can see here is an abscess. You can see the reactive hepatitis around this abscess. So that was the indication for puncture. So we punctured immediately this patient, and that was pus that we got. So we then put a drainage in. So that was the consequence. So we can detect that at a very early stage, and that means also that the patient can be dismissed earlier from hospital. Okay, so the cystic artery may supply these polyps. So this is a small polyp here, 5 millimeter in size, and you can see the cystic artery, and you can see the enhancement of this polyp quite nicely. Okay. Adenomyomatosis at the tip of the gallbladder. So you know that there are typical finding on grayscale. You can make the diagnosis on grayscale, but just to learn how it looks like with sears, we did this study with a linear probe, and you can see quite nicely that we have these tiny cystic areas. These are the Rokitansky-Aschoff sinus, and you can see there's a clear demarcation between the adenomatosis and the surrounding tissue. So there's a benign finding, but the patient who had several cancers in the family said, "I would like to have that out, this gallbladder," and that is how we found this tumor here. We could confirm the diagnosis by that. So this is a patient, 61-year-old, with gallbladder stones since many, many years. She didn't know how long, but she says it's more than 20 years. So, and this was the grayscale image. And when you give contrast, you can see not only that the tumor is enhancing, but what you can also see is the infiltration of the liver, adjacent liver. So this is something that is, of course, important for the surgical management of this patient. And you can see it's now washing out. And the washout zone is smaller than the hyper-enhanced zone that we saw first. So that's the same story as what you saw with the liver metastasis before. Okay, and this is the late phase. Okay. Okay. We've seen several patients who have metastasis in the gallbladder wall, and they all behave the same. So this is here a patient with a melanoma, and so far I have 5 patients with metastasis of the gallbladder wall, and all were melanomas. And they all behave the same. If you look now at the contrast study, you can see the cystic artery, and you can see from the cystic artery bubbles running into the tumor. This is a metastasis, liver metastasis. So of course all these patients have advanced diseases, and you can see tumor, tumor, this is sludge. Here's sludge. But you can differentiate between sludge and tumor. This patient had 5 metastases in the gallbladder. So interestingly is that this tumor, this rather big tumor, is not infiltrating the liver. And that is something that we saw in all our patients with metastasis to the gallbladder wall. probably because the low resistance of the lumen of the gallbladder is the reason why they start to grow in the wall of the gallbladder, but then they expand to the lumen. Okay. That was the end of my talk. Thank you very much for your attention.
Thank you so much. Do a little shifting of computers. And our second speaker will be Dr. Paul Sidhu, who will talk about a liver elastography.
Here's the catch. There it is. Right.
No, it's just this.
It's this one, is it?
Yeah, no, it's this one. The only thing is... there we go. Okay. So that should work.
Okay,
Yeah,
now
and then it'll come up in a
Okay.
minute. Remember, it takes a little while.
Yeah.
And you got to click twice.
Okay. Thank you very much. I'm going to just change direction now, going from contrast-enhanced ultrasound of the liver, and we're going to have a look at liver elastography. Bear in mind that the liver elastography we're going to be talking not about focal lesions here, but diffuse liver disease. Now, I'm just showing you this slide at the very beginning because it pertains to the United States, just to show you the prevalence of chronic liver disease in the United States, but more importantly, to actually demonstrate to you the increase in non-alcoholic fatty liver disease in the United States. And this is going to be a big problem in the future, if it's not already a problem. It's becoming a higher proportion of your chronic liver disease. But this is not true of the rest of the world. Chronic hepatitis B and chronic hepatitis C are the two main chronic liver diseases that affect the liver to give you chronic liver disease. And if you look at the United Kingdom, 1 in 350 people are chronically infected with hepatitis B, and 0.3 to 0.7% of the UK population is infected. Now, this transcribes to a patient population at King's College Hospital, for instance, of 9,000 people in the chronic hepatitis clinic. So this is an enormous problem for us, and it will become a bigger problem in the future. We're all used to looking at the liver, and we can, by sticking your thumb up in the air and guessing, you can say, well, yes, this is a normal liver. Do you have a pointer, Carol? Because this one's not working. It's not coming up on the screen. Anyway, you've got a normal liver and you've got a cirrhotic liver. It's very easy for you to differentiate between those two. Thank you. Okay, thanks very much. Very easy to differentiate between the normal and the abnormal, but it's this subjective assessment of the rest of the spectrum of liver disease that you're being asked to make a diagnosis on by your referring clinicians. So you want to look and see if you can become more objective in your assessment of the degree of fibrosis or cirrhosis in your liver and hand it to your clinical teams to make a decision whether or not they're going to treat that patient or do invasive procedures. From a clinical viewpoint, the most important or clinical management is whether or not there's fibrosis in that liver and whether or not you're going to actually treat that or manage that patient. There are many ways you can look at the liver non-invasively. You can look at it at MRI, but we're concentrating on ultrasound today. Basically, you want to avoid a liver biopsy. It's the gold standard, but it's poorly suited for active monitoring because you can't keep doing a liver biopsy. You can't do a liver biopsy every 6 months. And if you're the patient, this is the question you're going to be asking your physician. What are there in non-invasive biochemical tests to tell you whether or not there's fibrosis or cirrhosis in that liver? There are well-established clinical tools that look at this. The most popular is the fibro test and the APRI score, which is an AST platelet ratio. And I'll talk more about the King's score later on as we're going on. Non-invasive imaging tests to tell you whether there's fibrosis, cirrhosis, or a normal liver include all of these. And most of these are not very good. elastography is probably going to be the best tool you're going to have with ultrasound to look at liver stiffness currently. MRI, you can use MRI to look at liver stiffness, but you have to think of the expense and the size of the population that you're assessing for the degree of fibrosis. And again, I will show you later on some more data on the MRI versus ultrasound. So what are you doing when you're looking at a biopsy? Why are you biopsying the patient with a chronic liver disease? It's to stage the fibrosis. Staging the fibrosis into significant, well, normal, significant, or severe. If you've got significant fibrosis, you can use disease-modifying therapy to try and control that. If you've got severe established disease, cirrhosis, you're looking, therefore, to monitor the patient for the effects of portal hypertension long term. How do you classify fibrosis? There are several different ways of classification. The most popular way of classifying liver fibrosis is the Metavir score, and this is divided in F0 to F4, where F0 is no fibrosis as normal, and F4 is cirrhosis, and there's a spectrum of disease between the two. You're looking to establish whether or not this patient is F2 or above, or is F4, to give modifying treatment or monitor the patient. But also note that if you've got inflammation in the liver, you can classify that as well. And it's important because inflammation in the liver affects your fibrosis score, your elastography score. A second way of doing this is the Ishak score. This is a wider spectrum of classification, going from 0 to 6. This is the score we use in our institution, but it's a matter of preference as to which score you use. The most popular score to use is the Metavir. So what are you looking for? Well, you're looking to assess, to treat, survey, and prognosis of the patient based on your ultrasound findings. Why don't you want to do a liver biopsy? Well, it's the current gold standard, and it will tell you how much fibrosis there is. But there is an adverse effect. You will kill 1 to 3 in 10,000 patients doing a liver biopsy, which is okay if you're the 9,999 patients, but not if you're that one patient. There is a sampling error, and there's observer variation. Chance of misdiagnosis in a 2.5 centimeter sample is up to 25%, and the stage of fibrosis may differ between lobes of the liver in 33%. So you're up against a gold standard that's not really a gold standard. And with a liver biopsy, you're sampling over 1 in 50,000ths of the liver. So let's move on quickly now. With that background, you know what the fibrosis score is, you know what you're up against. How can you do a non-invasive ultrasound examination to quantify the amount of fibrosis? Well, currently we're going to talk about 3 different techniques of elastography: transient elastography, or fibroscan, as most of you will know it as, strain elastography, and shear wave elastography. And I'm going to be talking around the guidelines issued by the European Federation of the Societies in Ultrasound in Medicine and Biology on the clinical applications of elastography. Transient elastography is this fibroscan you may be familiar with. This is a large, heavy ultrasound machine, but it's not really an ultrasound machine because it doesn't give you a 2D picture of the liver. You are placing a probe over an area where you think the liver might be. And this is used by physicians rather than radiologists. So your guess is as good as mine as where they're putting the probe to look at the liver. Having said that, it does work. You're propagating a pulse into the liver, and you're analyzing the stiffness of the liver and Young's modulus and measuring it in kilopascals. You take 10 valid measurements and you vibrate that there. Your success rate about 60%, and you're looking for an interquartile range that's between the 25 and 75% range, that all your readings around the mean to give you a diagnosis. What's good about it compared to biopsy? Well, it's non-invasive, there are no side effects, you can do as many examinations as you like. It's 100 times greater sample of liver, and it's very much less costly than a biopsy. Is it any good? Well, the early papers indicated that for significant fibrosis, you have an accuracy of about 0.88%, and for cirrhosis, you're up to nearly 100% diagnosis. So it's quite good at doing that. And what's more, it quantitates it for you. It gives you a figure as to what is going on. Are there limitations to this method? There are limitations, and the principal reasons are obesity. If you've got a fat patient, you're not sure if you're putting the probe on a rib or on the liver, if you can't see where the liver is. So you're going to get poor readings. And this is based on the waist circumference, and it also takes a lot of time to actually learn how to use this. The company came out with a probe which is for obese patients, much better, the larger probe, XL. It can deal with the waist circumference as well, and this improves your diagnostic thing. But there's a great variation. They measure the elasticity in kilopascals rather than meters per second is what radiologists are used for. And you can see the cutoff points for significant fibrosis and chronic hepatitis B are quite variable, right down to 5.2. And this measurement has now entered the clinical guidelines for the European Association for the Study of the Liver, which is the same as the American Association of the Study of the Liver, which says that you should add in transient elastography into your pathway to detect cirrhosis and fibrosis as part of your clinical workup. But, as always, there are further studies out there to show whether or not this will reduce your biopsy rate. Adding this, will it reduce the biopsy rate? Well, yes, in this particular study, it reduced it by nearly 80% by combining it with other non-invasive tests. And if both those tests agree to whether or not it's normal or cirrhotic, you can avoid biopsy. If those tests agree, you still go on to do biopsy. However, the recommendations still state that even if you've got this continuity and you do have concordance with your imaging, you do not abandon liver biopsy completely. So it doesn't stop liver biopsy, but it certainly reduces it by a great deal. A meta-analysis of all these studies showed that there is no optimal cutoff for individual levels of fibrosis, and there was a large range of measurements over there. So it's not perfect, but it's better than what we used to have before. This method doesn't visualize the liver. You put your probe over there, and it's the best guess that you're actually hitting the liver. But it seems to work, and this is the oldest established procedure. Strain elastography is slightly different. You will be familiar with strain elastography in your other clinical practice, in thyroid disease, for instance, where you're using pressure and movement to cause displacement of the tissue, and you're looking at the response of the tissue to that displacement and labeling it as either hard or soft. In this machine, which is the real-time elastography from Hitachi, it's labeled hard is labeled in blue. Other machines label hard in red. So there's no standard out there with the companies at the moment. And it's a very useful tool in that you can measure a strain ratio between the hard area and the soft area to get an idea of how much harder the tissue is in that area compared to normal tissue. How do you use it in the liver? Well, I have some experience in using this machine. You can incorporate it into your measurement package by using a linear probe, and you angle it up towards the heart, looking at the liver with cardiac pulsations causing the same sort of push that you were doing on the thyroid gland to give you a histogram of that area of tissue. And basically, from there you can measure a strain histogram. You measure the differences in color through that gam, and from there you can measure mean strain, standard deviation, area of blue change, which is harder, the complexity, etc. And from this you can work out how stiff the liver is. So slightly different method from just putting a pulse in. You're actually using the heart to compress the liver. And it's the advantage of this method is easy to integrate into your machine. You're looking at the liver, you can see what you're looking at, and you have a display of color pattern through that liver so you can understand which is harder, which is not harder. Early results from this technique, and this is quite a few years ago, showed that this is a rock curve. You're much better if your line is nearer this area, and it was underperforming compared to other non-invasive tests. But improvements in the technology over a period of time has shown that this is improved quite considerably so that it's now on par with other non-invasive examinations through the liver. And this recent paper in radiology has confirmed that strain elastography, looking at the liver, is as good as, and in some cases with severe fibrosis, it actually outperforms the other non-invasive liver tests. So it's a useful test, again, to look for fibrosis, and it can quantify the degree of fibrosis by using those histogram measurements. Slightly more difficult to use than the next few examples are going to use, because you are using a linear probe. you're angling it up towards the heart, and you're relying on visualizing that liver against the heart and looking at those pulsations. The next kit on the block is shear wave elastography, and there are 3 companies out there with shear wave elastography on their machines: Philips, Siemens Medical Solutions, and Supersonic. I have any experience with the Siemens at the moment, and I will show you some of the results that there are out there for that machine. This is called ARFI, acoustic radiation pulse imaging, and basically what you're doing is you're sending out a longitudinal wave which goes out in a horizontal fashion, causes tissue displacement, and you're measuring the speed of the returning velocity in that box. So the sample box is a smaller sample box, and the degree of shear wave velocity is comparable to the amount of liver stiffness. Basically, the faster that shear wave, the stiffer your liver. The stiffer your liver, the more fibrotic or cirrhotic it is. It's basic, simple principles. And this is what it looks like on the machine. You've got your region of interest, and you can vary the depth of that region of interest right down into 8 centimeters. It only used to be 5 centimeters. It goes down to 8 centimeters, and you get a reading of the machine. Basically, you target the segment, you press a button, avoid vessels in suspended respiration, mechanically stimulated short duration pulse. You get XXX if there's no reading, otherwise you get a measurement there. You wait for it to cool, and you repeat the procedure 10 times. The standard teaching now from all the manufacturers is you make 10 measurements. You make 10 measurements only because the first FibroScan did 10 measurements, and we've looked at all our measurements. In fact, 10 does give you the best readings. 7 gives you a good enough reading. Anything below that is not good enough. 5 doesn't give you an accurate reading. So you've got to do, as it will be standard, 10 readings for this. Take the mean or the median and measure the interquartile range. Like with any new technique, you have to look at reproducibility, and this is our study. Don't read it all. Just look at this area here, segment 3, what the measurements were, segment 5 and 6. So clearly there you don't want to use segment 3 for your measurements, and the reasons being heart movement, pulsation, you don't get an accurate reading. So when you're doing your readings for any shear wave velocity measurements, you should look at segments 5, 6, 7, or 8. Segment 3, avoid, and you should also take the measurements at a maximal allowable capsule to box distance, meaning away from the capsule edge. It's well recognized that the nearer the capsule you are, even with histology, the more fibrotic your specimen is. So avoid the capsule. And this has also been pointed out in a further study from Merco's group in Italy, that is more reproducible when applied to deeper portions of the right liver, left lobe not reproducible, sensitive to movement. So how do you do a shear wave measurement? You turn the patient into a lateral position, quick suspended respiration, don't breathe in and hold your breath. This increases the stiffness of your liver. You're going to get an inaccurate reading, and briefly do that measurement. How good is it? Well, this is the first paper published in radiology by Friedrich Rust's group from Germany, and I'm told this is the most cited paper in radiology currently. The 81 patients were evaluated with ARFI, and they showed, comparing this with FibroScan, it was the easiest to perform scanning method, and when integrated to the ultrasound system. It was comparable to the gold standard, which you're comparing is the liver biopsy, and the transient elastography, which has been there for a while, the FibroScan. It was good as, if not slightly better, than the transient elastography, and you could work out velocity measurements for different stages of fibrosis. A meta-analysis, again, shows that it's a good diagnostic tool for significant fibrosis and excellent for severe fibrosis and liver cirrhosis. So we're looking at a pattern here with shear wave, strain elastography, transient elastography. It's very good at telling you what's normal. It's very good at telling you what cirrhosis is. But in between those two, it's still not quite good at teasing out the exact levels of fibrosis through the liver. When we evaluated this, we had to set up our own program in our hospital, and to do this, we had to establish our own normal range. Each of the machines are not reproducible with the measurements. So if you've got One machine that gives you a value of 1.21, another machine it may give you a value of 1.41. So you have to beware that the machines do not give you the same readings. So if you're going to establish this in your clinical practice, you're going to use the established criteria for that machine or establish your own. So we looked at 169 patients looking at segments 7 and 8, and what we did, because we don't run a day case liver biopsy service, we immediately after the examination biopsied the patient. So you took it from the same sort of area as much as you could. So you've got a very robust method here for looking at what your measurements are. And this is just the demographics of the patient. And we looked at drawing out our patients, and 1.09 meters per second was normal, and 2.76 in Ishak score cirrhosis. So you can see how wide apart those measurements are, and this is a very good tool to tell you normal or cirrhotic. You could probably say to yourselves, well, I can tell on B mode what is normal and what is cirrhotic, but that is a subjective assessment. You have now got an objective number to give to your clinical colleagues to tell them, yes, you should biopsy, no, you should not. And these are the ROC curves from that particular study, which demonstrates that with with the significant and the severe cirrhosis, how in cirrhosis itself, the shear wave elastography completely outperforms everything else. So it's an excellent tool for that. And you can then, from that data, quantify, look and see what is the best cutoff point for telling you whether or not there's significant fibrosis, where you treat with antivirals, or there's severe fibrosis, you manage the complications of disease. And the cutoff points for our study was 1.3 meters per second with the Arfi and Siemens machine for significant fibrosis, and 1.83 for severe. And that's quite a difference between the two. So you have a useful tool there in your cupboard when you're looking at these sort of patients to actually see and make a diagnosis for the clinicians of what is severe, significant, and what is normal. So what else is out there? We've seen that that's a point shear wave elastography. You've got a box and you put it over in an area. The other companies look at a bigger field of view and they color code that box. This is out from General Electric, GE, which have now produced a shear wave elastography machine. And this is a shear wave measurements in a targeted area in someone who's got a normal liver and someone who's got an abnormal liver. So this allows you to see what areas are different in color, and you can target those areas where you think you're going to be better at picking up variation in velocities and actually go for the area which is abnormal. Remember, disease may be patchy. We've seen it from the liver biopsy, so you know where you're sampling. And again, these machines give you, and we've looked at this with reproducibility as well, this particular shear wave method gives you a very good reproducibility at 0 and 6. It gives you a very good separation of the measurements, and it gives you a very tight reproducible interquartile range. So it's improving all the time. You're getting tools that are better and better. And this is a short, small number of patients. There were 63 patients in this particular study. And again, it's mirroring the other shear wave and transient elastography studies where normal is very normal and cirrhosis is very abnormal. But it also, in the small number of patients, you could significantly tell that there's a significant difference between 0 and 6 and 1 and 6. So it's starting to tease out those areas where fibrosis is a little bit patchy, a little bit variable, and you're not quite sure which category to put it in. So where are we at the moment with shear wave elastography? Well, it's a reliable tool for assessment in the liver, and it's reproducible. You should go as deep as possible in the right lobe of the liver in a brief period of suspended respiration away from the capsule. Avoid segment 3. There are limitations in obesity, and there are limitations when you've got a very fatty liver. Remember, you're using ultrasound. Any limitations for ultrasound in general will apply to this as well. So if you've got a very echogenic liver, it's sometimes difficult to get those readings as accurate as you can. It's comparable to the existing technology, the FibroScan, the transient elastography. but it's probably going to prove in the long term to be better because it's improving all the time. And it's very good in the late stages of fibrosis and cirrhosis, but still really not proved in those early stages of fibrosis. So where do we go from here? Well, the nation that has the most established practice in elastography is Romania. They've embraced this technology really well, and they've issued guidelines, and I would encourage you to look at these guidelines because of this table. In this table, they've established what the evidence is, what the measurements are for different levels of fibrosis with the different machines that are available. FibroScan, the Siemens AFI method, the Philips ElastQ, the Supersonic, and the Hitachi. And they've established what's out there in the literature. And if you're going to start a practice looking at liver elastography, you should, with the particular machine you're using, this is what you should refer to. But how does it compare with MR elastography? Now, this is hot off the press. This is out of this month's Radiology from a Korean group who's looked at and compared shear wave measurements using the supersonic machine with MR elastography, and they are not comparable. The elastography measurements from MR are different from the shear wave elastography, just as there are differences between the different manufacturers of different machines. So you can't use one figure to tell you what the stiffness is of the liver with different modalities, and certainly not between the two. The MR outperformed ultrasound, but ultrasound still remained a robust measurement of the stiffness of the liver, and it was still reliable. The advantages, of course, of the ultrasound examination is that you can deal with the volume of patients that you will have. MR, it may be different in the United States, but certainly in the United Kingdom, we cannot deal with doing elastography, MR elastography on 9,000 outpatients a year. Nothing else will get done. So you've got to bear that in mind as well. So yes, elastography using ultrasound is good, but MRI outperforms the current techniques of elastography. So where are we with the actual measurement on biopsy for levels of fibrosis? Now, you're trying to look at a disease in continuity, compartmentalizing that into separate categories. So you're saying, this biopsy tells me it's a metavir F3 and not an F4. But when you're giving a shear wave velocity measurement, you're doing it in continuity. So it may be that you're going to have established over a period of time continuity in changes on the histology to cope with your new techniques of measuring velocities in continuity through the liver. So that may come in time. And certainly there are moves to measure a different entity called the collagen proportionate area, which gives you a better idea of the degree of disease in the liver and correlate that with your elastography scores. What do the guidelines say? Well, the guidelines essentially have confirmed what I've said to you so far. Point shear wave elastography, which is the AFI measurement, can be used to assess the severity of liver disease, fibrosis in patients with chronic viral hepatitis, and particularly in hepatitis C. That's where most of the work is done. And you're able to differentiate, different scanners cannot give you the same velocity measurements. So what you've got to do now is you've got to get more studies under your belt, look at all the different modalities, and try and establish in continuity with your histology what you're going to do. It's good at normal, it's good at cirrhosis, it's not so good in between those two. So really, this is what you've got to be looking for. You've got to do prospective validation for cutoff values in the future, and it's got to be multi-center to do this. Thank you.
Thank you so much. Sounds like we've got our work cut out for us. Our last talk for this section will be Dr. Anthony Hanbridge, and he'll be talking about gallbladder and biliary disease.
Thank you very much, Dr. Benson. Good afternoon, everyone. If I could have the lights down, please, Patrick. Oh, the lights can't be changed, so then I'll go ahead. I will continue. So hopefully the images will project well. In the last section of this course, we'll discuss the value of ultrasound when assessing the gallbladder and bile ducts. We'll identify the imaging features of acute conditions of the gallbladder and complications. We'll recognize some common pitfalls to avoid misinterpretation, and we'll very briefly discuss a number of conditions, including primary sclerosing cholangitis, cholangiocarcinoma, IgG4-associated cholangitis, adenomyomatosis, gallbladder polyps, and finally a case or two of gallbladder cancer. Now, I've left a few questions in just to engage the audience. What is the primary imaging modality used to assess the patient with acute pain in the right upper quadrant? Is it ultrasound, computed tomography, magnetic resonance imaging, or scintigraphy with HIDA? So for those of you who are doing the SAMs, the answer, of course, is ultrasound. Now, when patients present to the emergency department with right upper quadrant pain, finding the cause is a clinical challenge. And if you base your diagnosis solely on clinical evaluation and a few simple laboratory tests, you will be inaccurate a large number of times. So imaging is critical to management, and in my opinion, ultrasound should always be the initial imaging investigation for these patients. It's accurate, it's safe, it's inexpensive, it's available, and today it's highly portable. When patients present to the emergency room with right upper quadrant pain, they invariably come to our department with a requisition that states rule out acute cholecystitis. But in fact, less than 2/3 of these patients will actually have acute cholecystitis. And there's a whole range of other conditions, including choledocholithiasis, cholangitis, recurrent pyogenic cholangiohepatitis, liver abscess, rupture of liver masses, to name a few, that can mimic the presentation of acute cholecystitis. Ultrasound has an accuracy of about 88% in the diagnosis of acute cholecystitis. This is very similar to scintigraphy, but ultrasound has advantages in that not only can it diagnose acute cholecystitis, but it can demonstrate complications such as gangrenous change or perforation, and it can also offer alternate diagnosis when the gallbladder is normal. It's also less time-consuming. The majority of patients with acute cholecystitis have gallstones, and the pathophysiology is calculus obstruction of the gallbladder neck and cystic duct, leading to gallbladder distension and then variable degrees of infection and necrosis, all the while the patient's developing right upper quadrant pain, tenderness and guarding, and the spectrum of presentation is quite large, from relatively mild symptoms to very dramatic findings. The most sensitive ultrasound findings when diagnosing acute cholecystitis are maximal tenderness over the sonographically localized gallbladder in the presence of gallstones in the correct clinical setting. And we've known this for a number of years. A paper by Phil Rouse back in the mid-'80s in a prospective study of close to 500 patients showed that this combination of findings had a positive predictive value of greater than 90%. Gallbladder distension, diffuse wall thickening, pericholecystic fluid are secondary findings that are neither sensitive nor specific. But one finding I'd like to draw attention to is gallbladder distension, and give you this teaching pearl. Be very reluctant to diagnose acute, uncomplicated cholecystitis if the gallbladder is not tensely distended. I find that a very useful rule in everyday practice. So here's our patient, a woman in her late 30s with right upper quadrant pain for approximately 22 hours. And we can see immediately that there are gallstones and there was maximal tenderness over the sonographically localized gallbladder. So in that context, a positive predictive value of greater than 90% for acute cholecystitis. Note also that this gallbladder is tensely distended. Note that the wall is not thickened and we don't see pericholecystic fluid. So that shouldn't put you off the diagnosis. It's also very valuable, I find, when I go into the room to look specifically for the region of the gallbladder neck and cystic duct to see if I can demonstrate the obstructing stone. Because if I can, it adds additional confidence to my diagnosis. If I can't, it doesn't put me off if the other features are there, but I'm even more confident if I can demonstrate that stone. Another patient, a very similar history. We see immediately there are gallstones. There was maximal tenderness over the sonographically localized gallbladder. The gallbladder is tensely distended. In this case, there is gallbladder wall edema. So we can make a diagnosis of acute cholecystitis. But again, pay attention to the region of the gallbladder neck and cystic duct, and sometimes you have to work a little harder. So this is with the patient, left posterior oblique. We've moved the probe up intercostal, and now we've unfolded the gallbladder neck and cystic duct, and we can demonstrate the obstructing stone. It adds confidence to our diagnosis. Remember that today most gallbladders are removed laparoscopically, whether it's an elective cholecystectomy or in an acute setting, and we must always keep in the back of our mind the possibility of an underlying gallbladder cancer. Because if a surgeon removes a gallbladder laparoscopically and there is a cancer, and it's not foremost in their mind that there might be a cancer, it can have a bad outcome. This patient is 3 months post-laparoscopic cholecystectomy. There was a non-suspected gallbladder cancer in the specimen, and now we have seeding at the right upper quadrant port site and at the periumbilical port site. So when this patient, a retired obstetrician, presented one morning with acute right upper quadrant pain, we could see the gallbladder stones. We had maximal tenderness over the sonographically localized gallbladder. The gallbladder is distended. So I was very confident that there was acute cholecystitis, but I was concerned about this additional material in the gallbladder lumen. Is it tumefactive sludge or is it a tumor? And as we heard so nicely in the earlier presentation, we could use contrast ultrasound here, but this patient had a multi-phase CT. This high attenuation was present on the unenhanced images, so simply represents the gallstones. We can see a thin, smooth, enhancing gallbladder mucosa. There's some early gangrenous change, and there's pericholecystic inflammatory change, but no enhancing tumor mass. So we were very confident that all the changes in this case were due to inflammation, and the patient went on and had a non-eventful cholecystectomy. So what about gangrenous cholecystitis? It's not uncommon. You should look for asymmetric thickening of the gallbladder wall and intraluminal membranes from sloughing of the mucosa. Remember that the majority of patients with time will have a negative sonographic Murphy sign, and the symptoms and signs will shift away from the right upper quadrant. So often it's a very confusing clinical presentation. Here's an example. A man who had pain for 8 to 9 days came to emergency and had a renal colic CT scan for what I suspect was fairly non-specific abdominal pain. There were no urinary tract calculi, but we did note a distended gallbladder, and when you look carefully, there's a high attenuation line within the gallbladder lumen on this unenhanced scan. So we brought the patient immediately to ultrasound, and we see the sloughed mucosa giving you intraluminal membranes. You see this asymmetric wall thickening, which allows you make that diagnosis of gangrenous cholecystitis. It's also a distended gallbladder with a fluid debris level within it. Gallbladder perforation is the next step in the process, and it's a very significant step. Again, not uncommon, 5 to 10% of cases of acute cholecystitis, depending on the series, and it's significant because it can have a significant mortality rate. It comes really in three flavors: an acute perforation, where you get a generalized peritonitis, and then a subacute, which allows the process, the omentum comes up and walls off the inflammatory process, and you get a pericholecystic abscess. And then more chronic perforation, where the gallbladder sticks on to an adjacent structure, be it the duodenum or the colon, and you can get an internal biliary fistula, sometimes with passage of stones. Here's a case of a patient with pain for just over a week. We see this large gallstone in the region of the gallbladder neck, but there's an additional process here in segment 5 of the liver. And when we look at that more closely, this patient was septic. It has all the features of a liver abscess. And then we return and we look more carefully at the gallbladder, and we can actually see the point of perforation in grayscale. Note that this gallbladder isn't distended, and that's because it's perforated and decompressed itself, so that this distensibility rule doesn't work well once the gallbladder has perforated. And CT gives a very nice overview and has a similar sensitivity for demonstrating the point of perforation in the gallbladder wall. Emphysematous cholecystitis, thankfully, is rare, gas-forming bacteria. Often gallstones are absent. A little over 1/3 of patients will be diabetic, more common in men than women, and an important condition because of its high gangrene and perforation rates, and therefore high morbidity and potentially high mortality rates. This is a nice example where we see a very echogenic gallbladder wall, and the feature is the reverberation artifact, or so-called dirty shadowing, which is very typical of air in the gallbladder wall, or in fact air anywhere. And if you're unsure, and it can be difficult sometimes with ultrasound to confidently make the diagnosis, I would have a very low threshold for going on and confirming the diagnosis, as in this case, showing gas in the gallbladder lumen and gas in the gallbladder wall. Now, how does emphysematous cholecystitis differ simply from a gallbladder that's packed full of stones? Well, often the latter patient won't be acutely unwell, so that might be the first clue. But from an imaging perspective, we can actually see the gallbladder wall in this case as a very thin, smooth, echogenic line. And then there's a second acoustic interface, which is more irregular, which is the interface, the front edge of the stones filling the gallbladder lumen. And then look at the contrasting shadow from these calcified stones, a very clean, dark shadow. And this is the so-called wall echo shadow sign, or the West sign. And then a third gallbladder for you to consider and mull over. What's this gallbladder? Well, to me, the wall looks very similar to the case of emphysematous cholecystitis, but the teaching point is that the shadow is the important feature. And here the shadow is one of calcium. And of course, this is a calcified gallbladder wall of a porcelain gallbladder. Now, this is an elderly patient. This was a woman on a medical floor who had a number of medical conditions, and she developed right upper quadrant pain. And this is an ultrasound showing a large gallstone in the region of the gallbladder fossa, surrounded by soft tissue. We know it's a stone because of the very clean acoustic shadow. Because of her comorbidity, she was treated conservatively and returned a few days later with abdominal distension and a different pain. And now we can see the stone in the gallbladder is replaced by gas. There's gas in the bile duct, and of course the stone has migrated and is now sitting in a mid-small bowel loop. So this, of course, is gallstone ileus. And here we see that stone being delivered through an enterotomy at the time of surgery. Well, what about pitfalls and mimics? So this is very important. This is a lovely case that was given to me a number of years ago by Dr. Wilson when we worked together in Toronto. And this is a patient who came, rule out acute cholecystitis, and we can see the gallbladder here with the lumen almost completely obliterated, but one of the thickest gallbladder walls you're likely to see, this onion peel edema of the gallbladder wall. And when you look at the liver, there's increased echogenicity in the periportal triads. And of course, know your patient. Speak to the patient, look at the chart. The transaminases are up in the air. So this patient has acute hepatitis with secondary thickening of the gallbladder wall. This is another case. This is how it happened. Came from Emerge, rule out acute cholecystitis, had very severe abdominal pain. We see this stone in the gallbladder neck. There are additional gallstones. The patient was very tender, but was more diffusely tender in the gallbladder than just over the gallbladder. And when we look, I would argue that this gallbladder is not tensely distended. That near wall, to me, sags into the gallbladder lumen rather than being tensely distended and pushed out. So it should cause you to look a little more carefully. And when we rolled this patient left posterior oblique and looked very carefully in the right upper quadrant, we can see this focal enhancement of the peritoneal stripe with a little bit of dirty shadowing behind, and this is the appearance of free air. And of course, this patient had perforated the duodenal ulcer, and there is lots of inflammation in the right upper quadrant, which also involves the gallbladder, but there's also free air. So here the gallbladder is secondarily inflamed from a perforated duodenal ulcer. Here's another patient, rule out acute cholecystitis. The gallbladder is distended. There are no stones. There is some pericholecystic fluid. But the maximal tenderness in this case wasn't over the gallbladder. It was inferolateral to the gallbladder, and when we placed the probe in the region of interest, we could see this thickened hepatic flexure of the colon with an inflamed diverticulum that's perforated. You can see that little jet of extraluminal gas. So this is acute diverticulitis of the hepatic flexure of the colon, mimicking acute cholecystitis. Now, what about choledocholithiasis? Ultrasound sensitivities vary wildly depending on the paper, but at least 70% sensitivity, hopefully a little better than that. If the ducts are dilated, you'll do better. Harmonic imaging has improved our sensitivity, and you need to be aggressive and spend some time looking at the bile duct in various positions and with various patient maneuvers. Ultrasound is highly sensitive to detect biliary dilation, as in this case, and then you must follow the ducts distally. Do the segmental ducts communicate, as they did in this case, where we see a markedly dilated common duct, but your job still isn't finished. You must follow the duct down and determine the level and cause of obstruction, and in this case, it's a large stone. Just one small point, note here that we're imaging with sono-CT, so the shadowing from that stone is not what you might expect from a large stone because of the multiple angles of insonation, so-called dispersing the shadow. So you have to be aware of that and not be reluctant to make a diagnosis of a stone. If it's after hours and there's difficulty accessing MRCP, and you see biliary dilation on ultrasound, the patient's presentation suggests that there might be a stone, but you can't demonstrate it, then CT can be very useful, at least in our practice, where we have somewhat limited MR access out of hours. And here we see at the point of biliary obstruction, high attenuation within the bile duct. The teaching point here is if you're going to use CT, looking at this enhanced image, you can't say if that's a stone or if it's enhancing tumor. So if you're going to use CT, you must use an unenhanced series. And then if it's a stone, it will be quite obvious to you. And of course, if you have access to MRI, it's very helpful. Cholangitis, pain, fever, leukocytosis, abnormal liver function, so often there's a clinical suspicion. On ultrasound, there will often be biliary dilation, and there may be thickening of the walls of the ducts, and often stone disease or intervention can be the cause of cholangitis. So we're going to do another question. A 75-year-old woman presents with septic shock, clinical evidence of ascending cholangitis. The ultrasound shows biliary dilation proximal to an impacting stone in the distal common duct. What's the next most appropriate step in this woman's care? Should she have a CT with inclusion of an unenhanced series to confirm the dilation and the presence of the distal common bile duct stone? Should she have an MRCP to confirm the biliary dilation and the presence of the distal common bile duct stone? Should she have a direct referral for biliary drainage following fluid resuscitation and antibiotics? Or should she have conservative management with fluid resuscitation and antibiotics? And the answer is that if she has cholangitis, and you see the biliary dilation and the stone on ultrasound, once that patient's resuscitated and covered with antibiotics, she should go directly and have the condition treated and the bile duct drained. And here, this is an elderly woman who presented with septic shock. We see the portal vein and immediately anteriorly a markedly dilated biliary system with sludge and stones within the common duct, and that's exactly what happened. She was resuscitated, given antibiotics, and sent immediately from the ultrasound department to endoscopy, where this image is taken from her procedure at that time, confirming the findings. Now, a few brief words about a number of conditions in the time remaining. Primary sclerosing cholangitis, autoimmune, can affect the intra and extrahepatic bile ducts and will ultimately lead to cirrhosis and liver failure. The definitive treatment is liver transplantation. Remember that 70% of patients with PSC have ulcerative colitis, and 5% of patients with ulcerative colitis will develop PSC. And if you have PSC, you have a lifetime risk of cholangiocarcinoma of 10 to 15%. And this is a nice example of PSC, very typical appearance of this smooth thickening, a long segment thickening of the wall of the common duct. You can, of course, get skip lesions, associated segmental biliary dilation. These patients come for screening ultrasound to try and look and ensure that there isn't a developing cholangiocarcinoma. So you're looking for new biliary dilation, which we saw in this case intrahepatically in both lobes of the liver. So again, you must follow those ducts centrally. Do they communicate? And at the level of the common duct in this case, we saw material, polypoid, papillary excrescences into the common duct. So is that sludge or is it tumor? And Doppler and indeed contrast ultrasound would be very helpful here. But even with spectral Doppler, don't just rely on color. You need a spectral tracing. We could see some arterial flow, and this was a polypoid cholangiocarcinoma. Another condition to be aware of is IgG4-associated cholangitis, and the imaging features can be very similar to primary sclerosing cholangitis, the smooth thickening of the wall of the common duct, and in this case, extending up into the central right and left intrahepatic bile ducts. Be aware of this condition. It's often associated with autoimmune pancreatitis and indeed other autoimmune conditions. And when you're imaging these patients, look for clues on the imaging that might tip you towards an IgG4 associated cholangitis. It's important because unlike PSC, it's steroid responsive. So it's important to make this diagnosis. Here's another very nice example on CT where we see the thickened bile ducts, smooth wall thickening, the sausage appearance to the pancreas. It's bulky, it has a slightly low attenuation, and in this case, look around the rest of the abdomen. This patient has early retroperitoneal fibrosis, so that should prompt you to consider the diagnosis and suggest that the patient have IgG4 levels obtained. Adenomyomatosis, we see this all the time. The so-called ring-down artifact or comet tail artifact from cholesterol crystals in the Rokitansky-Aschoff sinuses, shown here histologically within the gallbladder wall. But I want to draw your attention to two particular types of adenomyomatosis that can sometimes cause confusion. The first I'll show you is this hourglass adenomyomatosis, where you get mass-like thickening around the waist of the gallbladder. And if you look carefully here on the near wall, there are a couple of high attenuation foci. They're not causing comet tail artifact, but that may suggest a little bit that you're dealing with adenomyomatosis. There's often stasis in the fundus. In fact, stones are often trapped in the fundus of these gallbladders. We see it there in sagittal, here in transverse. We put on color Doppler, and not all color is flow. Remember I said earlier you have to do spectral tracing, and this is twinkle artifact from cholesterol crystals in this focal thickening. So this is hourglass adenomyomatosis, and we've also already seen a nice example of fundal adenomyomatosis in this session today, and this is another example where you get this thickening of the gallbladder fundus. And when we look with a higher frequency probe here, you can actually see an intact mucosa. And this thickening is very typical of fundal adenomyoma and is not gallbladder cancer. That brings us on to gallbladder polyps. Here's an example of a growing polyp starting at 3 millimeters in 2004. And by 2013 had grown to 16 millimeters. We didn't set out to follow this polyp. It just so happens that this patient has chronic hepatitis and comes for regular screening ultrasounds for hepatocellular carcinoma. But we've watched this polyp grow, and this patient has also had multiphasic CT scans for their liver, and we can see that this polyp is enhancing. So it begs the question, at what point should we start getting concerned about this polyp, if at all? And it brings us to my final question, which is a 35-year-old woman presents with epigastric pain, and the ultrasound demonstrates a solitary 0.6 centimeter gallbladder polyp. What is the best course of action for this finding? Should the patient be referred to the surgeon? No need for follow-up or other action. Follow-up ultrasound initially in 6 months, or recommend CT or MRI to rule out a gallbladder cancer. So the right answer probably is no need for follow-up or other action. And one paper that supports this approach is Kerwin et al. In Radiology in 2011, and they had 346 incidental polyps on ultrasound. 43% of those polyps had ultrasound follow-up for a number of years. 12% of patients had cholecystectomy, and 45% had clinical follow-up for a number of years. 81% of their polyps, the vast majority, were small, 1 to 6 millimeters, 15% were 7 to 9 millimeters, and only 4% were greater than 10 millimeters. They had no cancers at all in their series of 346 polyps. And of the patients who had cholecystectomy, there were only 3 neoplastic polyps, all benign, measuring 7, 12, and 18 millimeters. And in their series, only 1 polyp showed growth on ultrasound, and it grew from 3 to 5 millimeters over a period of 4 years. So their recommendations, and recommendations I've seen and heard from other discussions and other papers, are for smaller polyps, dismiss them. Their recommendations were 7 to 9 millimeters, follow with ultrasound. I'm not sure I always do that, particularly in older patients. If I had an 88-year-old woman with a 7 or an 8 millimeter gallbladder polyp, I probably wouldn't recommend follow-up. But where you get interested are probably the larger polypoid masses, and particularly in younger patients, and perhaps it is a good idea to get a surgical referral for them. And here's an example. This was a case in our practice about 4 years ago where we saw this 2.3 centimeter polypoid gallbladder mass. We can see it there. We put on spectral, color and spectral Doppler. Clearly that's a vascular mass. We raised concern quite strongly about that polypoid mass. The surgeon elected to get an MRI to confirm the findings. I'm not sure really what the MR adds here, but either the patient declined surgery or was lost to follow-up. I haven't been able to establish which, and came back last year with this obstruction of the right colon from an invasive cancer involving the hepatic flexure, and if you look carefully, lateral to that ascending colon, likely tumor seeding in the paracolic gutter. So you have to have some concern when you see larger polypoid gallbladder masses. It's a judgment thing. This is a case from around the same time, 4 years ago. There's echogenic material within the gallbladder neck here. It could be sludge, but again, use Doppler, use contrast ultrasound, and we see this is a vascular mass. And this patient had a CT scan for staging. We see it is indeed a vascular mass, and this is another gallbladder cancer, and this patient is doing well 4 years post-surgery. So that brings me to my summary slides. Remember, be slow to diagnose acute, uncomplicated calculus cholecystitis if the gallbladder is not tensely distended. Look for the obstructing stone. Remember always underlying gallbladder cancers. If you think there might be a cancer, alert your surgeon. Air versus calcium, it's the shadowing that will make that distinction. ERCP directly if you see an obstructing stone in the common duct on ultrasound. There's no need to do additional imaging. On-enhanced CT, if you decide to do CT because you can't visualize a suspected stone with ultrasound, remember IgG4 associated cholangitis. It can mimic PSC and it's steroid responsive, so you don't want to miss the diagnosis. Small gallbladder polyps you can dismiss. And if you have a further interest, this is a paper. It's now getting a little dated, but I think it's still relevant today if you want to read a little more. And I thank you very much for your attention.